Hi, and welcome to the Society of Nuclear Medicine and Molecular Imaging's annual Patient Education Day. My name is Jerry Francoeur, and I'm a two-time breast cancer survivor, and I'm very active with Susan G. Komen and the Florida Breast Cancer Foundation. I'm also currently the co-chair of the Society's Patient Advocacy Advisory Board, which is made up of 14 patient groups across many disease types. This is actually the 10th year SNMMI and the Patient Advocacy Advisory Board have held our Patient Education Day, and the second time we have done it virtually. Much has happened in nuclear medicine in the recent years, and we look forward to sharing all of this with you with the newest developments with breast cancer imaging, as well as a look at what's coming in the future. Our schedule for today starts with a 20-minute session offering an introduction to nuclear medicine and radiation safety, followed by several excellent speakers who will address specifically breast cancer diagnosis and treatment. Following that, we'll have a question and answer period, and our speakers will join at the end to take part in that live Q&A. If you'd like to submit a question, please use the Q&A application here on our platform at www.slido.com/pedbreast, PEDBREAST. All questions can be asked anonymously, and we'll try to get to as many of them as possible. You'll also see a patient poll on the site, and I encourage you to take that poll, as we're going to be discussing it a little later, and it's only 3 questions. A note to any physicians or techs who are joining us today, we're pleased to have you, but please note there are no continuing education credits being offered today. And a note to patients, please be aware that this webinar is for educational purposes only. Please discuss your treatment plan with your healthcare team. I want to point out that all sessions are being taped, and SNMMI plans to place a recording on their website shortly. The other 2 patient education days are already up on the site. Finally, before I introduce our first speaker, I'd like to thank our event sponsors, because we could not do this without them. Advanced Accelerator Applications, Blue Earth Diagnostics, ITM, GE, and Lantheus Medical Imaging. So let's get started. This is going to be exciting. Our first speaker is Dr. John Sutherland from the University of Iowa. Dr. Sutherland serves as director of the university's PET Imaging Center and is a professor of radiology in the Division of Nuclear Medicine. He's also a professor of radiation oncology and a professor of physics and astronomy. He is also the chair of SNMMI's Research and Discovery Domain and co-chair of its Clinical Trials Network. He's going to share a very interesting overview of nuclear medicine, molecular imaging, and radiation safety. Please help me welcome Dr. Sutherland.
Hi, my name is John Sunderland. I'm a medical physicist at the University of Iowa. I'm going to spend the next 15-20 minutes or so going over what nuclear medicine is, with a little bit of radiation safety kind of folded in towards the end. So here's a roadmap where we're going. We're going to start just with a very brief comparison between anatomic imaging as compared to what nuclear medicine and molecular imaging is all about. Then we're going to get into what nuclear medicine actually is and how it works. We're going to go to what nuclear medicine is used for. We're going to do some diagnostic applications and therapeutic applications, which is a new and upcoming an exciting area, and then follow with some radiation safety considerations just at the very end. So to start off, just for context here, what you see on the left-hand side of the screen are 4 very common anatomic imaging techniques that you're familiar with. So for example, MRI in the upper left really is an image of the hydrogen density in your body. If you go to angiography, right next to that, you inject just a little bit of radioactive opaque liquid into the veins, and you can get exquisite, very high resolution images of the vasculature in the heart and other places by passing X-rays through it. If you look at CT down in the lower left, that's taking X-rays that are going through the body at about 1,000 different angles. We can put those together to create highly detailed anatomical images, which you see there. Ultrasound uses ultrasound waves that reflect back, give you real-time images, for example, of fetuses and babies. But all of this stuff looks at anatomy in the human body, whereas What we have in the area of molecular imaging is we're actually looking at function. We're looking at biochemistry. What you see on the left-hand side is an image of glucose metabolism. So we're not looking at structure here so much as we are, ooh, look at the brain. The brain has a lot of activity. The heart has a lot of activity. If you look more importantly in the chest, you can see the tumor where you have cells that are dividing rapidly. They're metabolizing glucose rapidly. So we can see very clearly what that is and distinguish what might be a cyst or some other lump from actual active tumor. If you look in the upper right, we have a brain scan, which is distinguishing a normal brain. We're looking at dopamine storage here on the left, Parkinson's disease on the right. Anatomically, these two structures look the same on an MRI or a CT, but here we can see very clearly that the function is compromised. And if you look down below that, we're looking at perfusion of the heart, what parts of the heart are actually getting blood. We're looking at function here. So on the left-hand side, anatomy, right side, function, which is our nuclear medicine molecular imaging biz. So we're going to go from there and get into what is nuclear medicine and how does it work. So in all cases, when we do a nuclear medicine study, we are administering a tiny, tiny quantity of drug that has a radioactive atom attached so we can trace its path through the body. So what you see here on the left is a molecule, it's a glucose molecule again, that happens to have a fluorine-18, a radioactive atom attached. This is like my kids, they carry around cell phones, and I can track where they go all over town because the cell phone is transmitting radio waves and the like, such that I can see where they are. Similarly, when we get radioactive decay, we can place where that molecule is in the body. So we are tracing where the glucose goes in the body over time. Now, what we're doing is we're injecting a tiny quantity. And when I say tiny, I mean tiny. When we do one of these studies with this radioactive glucose, we're injecting about a millionth of a single grain of radioactive sugar. So the mass quantity is small. There's almost no possibility for side effects or anything like that. This is a tracer methodology. And then we use special scanners to detect the gamma rays from the nucleus of the radioactive atom. Now, we're not doing magic here, and we're not doing anything unnatural. We're using what Mother Nature gave to us. You're probably all familiar with the periodic table you'll see here, and all familiar with carbon, which we see here. There's two stable isotopes of carbon, carbon-12 and carbon-13. But if we put one extra neutron into that nucleus, we end up with carbon-14, which is radioactive. It's unstable. It decays with a half-life of about 5,000 years, and this is what we use for carbon dating. If we take a neutron away, then we end up with carbon-11. We now have too few neutrons and too many protons. It's unstable. This has a half-life of 20 minutes, very unstable, but we can use this and image it with positron emission tomography. And in fact, what you see in the lower right here is an image of C11 choline, which allows us to detect prostate cancer quite sensitively. You can see in the groin area, a little tiny dot, which is where a hidden prostate cancer is metastasized. So this is just to give you a little bit of a harbinger of where you're going to be going in this invention, not just this, but other talks that are coming. We're going to look at radiopharmaceuticals because in nuclear medicine, we only see what our molecules are targeting. And so what we have on the left is F18 fluoroestradiol, FES, which is very specific for not only breast cancer, but estrogen receptor positive breast cancers, which will help a physician guide a particular kind of therapy that will be effective to patients who have this particular kind of breast cancer. In the middle, we have F18 DCF-PYL. This is a PSMA prostate cancer imaging agent, recently approved just as FES was just to the left. This was just recently approved, a highly, highly sensitive way to detect the spread of prostate cancer. This is going to be a game changer in the way prostate cancer is managed. This too was just recently approved and is hitting the market. And on the right is copper-64 dotatate. We've had dotatates approved before, but not with copper-64. Copper-64 is different because instead of a half-life of an hour or two, it has a half-life of 12 hours, which means they can make it centrally in St. Louis, and they can ship it by FedEx anywhere in the country, even up as far as Alaska. It'll be there the next day, and so now everybody has access to this, which is used for somatostatin receptor imaging and neuroendocrine tumors. Once again, highly specific to cancers and to molecules. Going to go very briefly over the three kinds of radioactive decay. There's negative beta decay when there are too many neutrons. There's positron decay when there's too many protons, and there's alpha decay, which we're not going to discuss today. There's really only three of them. The particles that they emit, they only, just an electron or a positron, they really only go a millimeter or so. We don't worry about those so much, but we almost in all cases get a gamma ray at the same time. And gamma rays are very penetrating. They go way more than a millimeter, and they can actually make it outside of the body where we detect them with our scanners. And if they're positron emitters, because they have too many protons, not enough neutrons, we use a PET scanner. If they decay by beta decay, we use a SPECT scanner, which is below. PET is usually a little bit higher resolution and a little bit higher sensitivity, but they're both highly useful and both great imaging. So this is how it works. We generally inject in the arm, although in this center video you can actually see it being injected in the foot, and you could actually see how, and this is what happens when we inject one of these radioactive radiopharmaceuticals into the body. It goes into the vein, it goes to the heart, it goes to the lung, it spreads to the different organs, to whatever physiology that molecule is supposed to go to. So this is going to start again in a minute. We'll look at it again. But then on the right, we image. The imaging takes on the order of 15 minutes on a PET scan, 30 minutes on a SPECT. So once again, if you see this going up, you see it going into the lungs, into the heart, going into the rest of the blood, so it can be delivered. Here we're only 1 minute out right now. And pretty soon you're going to see it starting to go into the kidneys. The kidneys are getting it. It's filtering it out. The bladder just filled up. It's going to the heart. You can see the brain is using the glucose. You can see the heart is using the glucose. But if it were a different agent, the distribution would be different. And that's what we do. So I'm going to launch from here into what nuclear medicine is used for. So I'm going to go through some diagnostic applications, current and upcoming, and then some therapeutic applications, which are also actually quite exciting and game-changing. This is just a brief slide with some bread and butter stuff that nuclear medicine imaging things that we've been doing for decades, frankly. We've been doing the cancer imaging with FDG and PET. We look for cardiovascular disease using SPECT imaging or PET imaging. I'm showing this pulmonary embolism imaging because on the left-hand side, this is one we don't inject. This is a radioactive gas that we inhale. We use that in combination with an injectant dose to see A, where air is getting, and B, where blood is getting, and we use that together. On the right-hand side, we're looking at, once again, the movement disorders, but we can look at amyloid imaging with Alzheimer's disease, etc. These are all exciting but old. What I'm going to briefly go over now are things you're going to learn about in a little bit more detail in subsequent talks. But I just want to introduce you, first of all, to this F18-FES, which I mentioned before. This is fluoroestradiol. This was just recently approved within about the last year or so. It's used in the detection of estrogen receptor positive lesions as an adjunct to biopsy in patients with recurrent metastatic breast cancer. This helps guide the physician to the appropriate treatment for this particular patient. It is approved by FDA, and it is also being reimbursed. Here we're going to go through, the next two are both PSMA prostate cancer imaging agents. This first one is gallium-68 PSMA. This is approved, although it's only commercially available through the University of California, San Francisco, and UCLA at this point in time. They're the ones who submitted the application to the FDA, so those are the people that are approved. Although there are academic institutions, the University of Iowa is one of them, who continue to perform these studies under an FDA-approved mechanism, an IND, on a temporary basis until we get access to these commercial agents, because FDA wants people to have access to drugs that are safe and effective. This is approved, and it is reimbursed by CMS and generally by private insurers, but you generally, as in all of these agents, you pretty much need pre-approval. This is a similar PSMA agent for prostate cancer. This one is labeled with F18. F18 has a half-life of 2 hours as compared with gallium-68 with 1. This one is much more easily transported from central production. This is, and it's not a university that submitted this, it's the company. This is newly approved just within the last few months. It's available now in some major metropolitan areas, and the availability is rapidly expanding. As I said, this is going to be a game changer for prostate cancer management. And here, as I mentioned, is the copper-64 dotatate. gallium-68 dotatate has been approved. This does functionally exactly the same thing. The point here is this is available nationwide. They can get it to any hospital that's licensed, that's actually licensed to have it in the country, and that's exciting and a big boon to the neuroendocrine tumor community. And the last one I'm going to point out, these are 3 brain imaging agents, Alzheimer's disease agents that image amyloid. These have been approved, frankly, for almost a decade, but they haven't been used because Medicare, CMS, does not reimburse for them. They don't reimburse, not because they don't work, but because there is no therapeutic out there for Alzheimer's disease. Now, with the tentative approval of a drug, Aduhelm, that you've probably heard about in the newspaper, it is possible that these are going to be seeing widespread use to make sure a patient actually does have Alzheimer's disease before they have access to that very expensive therapeutic drug. And there are other good therapeutic drugs that are in the pipeline right now that are doing functionally the same thing. So this is another area of nuclear medicine imaging where it might manifest itself in order to help with management of patients in a very common and devastating disease. I want to just spend a minute on therapeutic applications here. So we don't just diagnose with nuclear medicine, we can actually do therapy. Now, fundamentally, we know that very large doses of radiation can kill cells, or at the very least damage the DNA so they can't divide anymore. This is the foundation of external beam radiation therapy that's been a staple of cancer therapeutics for more than 50 years now. But it kind of makes you think. Because here on the left-hand side is a gallium-68 dotatate scan. So this is a patient with widely metastatic disease in the body. There's no way that you can do surgery on a patient like this or anything. What you really like to do is to target just the tumors, which is exactly what this gallium-68 is doing. It's going straight to the tumors and almost nowhere else. So it makes you think, what if instead of injecting a tiny bit of gallium-68 dotatate, you injected a lot of lutetium-177 dotatate? Same molecule, same targeting, but lutetium-177 has a half-life of about a week. So what happens here is the radiation goes to the tumors, it sits in the tumors for a week or 2 and blasts the tumors, the neuroendocrine tumors that they're bound to, with radiation to the point where hopefully you give the tumors a lethal dose, and what you end up with is a patient who, in this case, is virtually disease-free. This is almost like magic. Not all patients respond like this, of course, but this is a very effective way to treat metastatic disease. Neuroendocrine tumors are an orphan indication, which means there are not a whole lot of those. Prostate cancer is a much more common disease. Just to follow up, lutetium-177 dotatate was approved in 2018, and it is being used all over the country now for the therapy of neuroendocrine tumors. But moving on to PSMA for prostate cancer, once again, we have this imaging agent that goes very specifically to the tumors. So the question is, what happens if we label it with a long-lived radionuclide, lutetium-177, with that half-life of almost a week, and we inject a lot of it? So here are 6 cases, A, B, C, D, E, and F. In the first image, you see in red where the gallium, the imaging agent, shows where the tumor was, and then in B, you can see after therapy what the response was. So once again, the first 3, you see the disease almost completely eradicated. In D, E, and F, you see partial response, but certainly dramatic response. And so this is all exciting. This is not approved yet, but the phase 3 trial, the one that they're going to use to try and get it approved, has functionally completed. They've done their preliminary analysis, and they have met their statistical endpoints of prolonged overall survival of patients who receive this treatment. So they will be applying to FDA, and I wouldn't be surprised if in a year or so that this will be available to the general population, which is a huge step forward. Lastly, just spending a couple minutes on radiation safety considerations, just with regard to nuclear medicine. I just want to let you know we're all being exposed to background radiation even as we speak. Cosmic rays from space are coming down. We have radioactivity in Earth. We have radioactivity inside our bodies, and as well as the radon that's in our basement. We know about how much radiation we get. We get about 1 millirem per day just from background radiation. So if we bear that in mind, we get 1 per day just in general. I want to put that into context. So 1 per day is background, not harmful. If we go up to 500,000 of those units of radiation dose, your whole body at once, that can cause acute harm and even death. So that's on the high side. If we go down a factor of 10 to 50,000 millirem, bearing in mind we get 1 per day, and we get that all at once, then we believe we can see a very, very slight increase in the downstream risk of cancer. It's not a sure thing. In fact, it's only barely blip above the normal cancer incidence rate. But that's about our level of detectability. Maybe we might be able to go down to 40,000 and detect a little bit of an increase there, which is why we go down a factor of 10 still to go 5,000 millirem per year, which is what we believe is safe for radiation safety workers at hospitals in nuclear power plants and stuff to be exposed to. So the technologists that are doing your scans, they're radiation workers, and at least at the PET center here, our technologists get on the order of 1,000, 1,500 millirem per year, which, by the way, is on the high end of what patients get for a single nuclear medicine procedure. We conservatively assume that even though we can't detect an increased rate of cancer at these low rates, we conservatively assume that maybe they can. So we just assume that less radiation to the patient is always preferable as long as we get the right information out. Okay, this is just putting this all into context. For a chest X-ray, you get about 10 millirem. That's about 10 days of background radiation. And for a nuclear medicine thyroid scan, you get approximately the same thing. On the other end of the spectrum, for FDG, that's one of those glucose PET scans along with a CT study at the same time, you'll get between 1,000 and 2,000 millirem or so, which, as I mentioned before, that's about what our technologists get over the course of a year. Still well within our safety margins. That's the kind of range that we're talking about for clinical scans. How much radiation would be considered too much in the grand scheme of things? Well, in our biz, the answer is more than is necessary. We don't want to give more than that. In all cases, these are prescribed drugs when we inject these radioactive radiopharmaceuticals into you, and the benefit of the imaging study far outweighs any potential risk. Each of the imaging procedures takes a certain amount of radiation to perform appropriately. This is well studied. We know what that is. Using too much radiation dose, it leads to unnecessarily radiation dose to the patient. But using too little may not provide enough information, which may be harmful in and of itself. If we're too worried about radiation, we don't give you enough, and our images are cruddy, and we don't detect the cancer that we're trying to see, then we're actually doing harm by not giving you enough radiation dose. So each imaging procedure is optimized for the medical question, the equipment being used, and the patient, and this is what is practiced universally in the United States. The SNMMI has initiated 2 dose optimization campaigns, the Image Gently and the Image Wisely campaign. One's for children, one's for adults. And both of these promote the appropriate procedure for that specific patient with the minimum amount of radiation dose necessary to provide the useful information that we're trying to get. SNMMI has a web page on these topics. It's snmmi.org/dose if you are interested in such things. And with that, I think I will conclude, and I hope you enjoy the rest of the program and the rest of your day. Thank you.
Thank you so much, Dr. Sutherland. That was an excellent introduction to nuclear medicine. A quick reminder to all of you, we are going to address the questions after all the presentations are completed, but you can submit your questions at any time, but all questions will be addressed after all speakers have spoken. Now, as we move into our breast cancer specific portion of today's session, I'd like to introduce Dr. Courtney Lawn Heath. She's a radiologist and assistant professor and assistant director of nuclear medicine residency and fellowship programs at the University of California, San Francisco. She is a recipient of the 2019 Semi-Hinken Government Relations Fellowship and currently serves on the Society's Breast Cancer Imaging Working Group. Dr. Heath.
Hi everyone, I'm Courtney Lawn Heath. I'm a nuclear radiologist and I'm an assistant professor in the Department of Radiology at UCSF, University of California, San Francisco. And today I'm going to talk about some of the very exciting ways that nuclear medicine and molecular imaging helps us find and evaluate breast cancer in the body. So I have no conflicts of interest, but I do want you to know I'm going to be showing some different imaging technologies, which includes some products, including what we use at my institution, UCSF, but I don't personally endorse any specific product or company. Now, first of all, I did say I was a nuclear radiologist, and I just want to clarify what that means. So, a nuclear radiologist is a radiologist as well as a nuclear medicine physician. So, they're board certified in both specialties. That generally means that after 4 years of medical school, they have done a 5 year radiology residency and a 1 year nuclear medicine fellowship. Now, both radiology and nuclear medicine involve reading medical imaging, but they're pretty different from each other and complementary. So, radiology gives us important information about the structure of the body. So, things like anatomy, where things are, the size of things. And that includes imaging studies like mammograms, ultrasound, and MRI. These are all images of the breast here. And meanwhile, nuclear medicine is primarily interested in information about function. What kind of cells are we dealing with? Do they have a certain kind of receptor on their surface, like, for instance, the estrogen receptor? And how are they working? Examples of nuclear imaging include molecular breast imaging, lymphoscintigraphy, and PET. And these and more are some of the types of imaging that I'm going to go over with you today. So I've broken down the different areas of molecular imaging into these three categories. The first one is looking for tumor in the breast itself. The next one is looking for lymph nodes so that surgeons can plan their surgeries better. And the next is looking for metastatic disease at the level of the whole body, not just the breast itself, but looking at the whole body for metastatic disease, otherwise known as a tumor that has spread outside of the breast. So let's start with looking at the technologies that let us look at for tumor in the breast itself. But first, I want to show you some mammograms and talk about breast density. This might be a concept that some of you are familiar with, especially if you yourself have dense breasts and live in a state that requires that you be notified about that fact. These are 4 mammograms in 4 different patients. They look super different from each other, right? And actually, all 4 of these mammograms are totally normal. Nothing suspicious. So despite looking so different, they are still all considered normal. And the real difference between them is how dense these different breasts are. A on the far left is primarily fatty tissue. That's considered the least dense type of breast. And D on the far right is primarily what they call glandular tissue. In other words, the glands that make milk make up the majority of the densest kinds of breasts. And then other people fall somewhere in between. And this is all just sort of a normal spectrum. Every person's different, and genetics have a little bit to do with kind of why one person is dense and another person is not. The reason I bring this up is because let's say I take a fake, this is a little like fake image of a tumor here, and let's say I try to hide it in each of these breasts on these mammograms, okay? It's clearly not too hard to find the tumor in a breast that's not dense. We can see it really well, but we put a red circle on it to make it even more obvious, but I don't think you need the red circle to see that. As we start looking at the denser breasts, though, that hypothetical tumor gets harder and harder to see. Until finally, when we get to the densest of all, I really don't think we can see it. For people with dense breasts, one very effective alternative way of looking for cancer in the breast is to use molecular imaging. And you can see the tumor in this breast on the molecular imaging picture that is essentially totally hidden on the mammogram. This image is called a positron emission mammogram, or PEM. And just like a regular mammogram, the setup's very similar. The breast is held between 2 paddles, but the nice thing is that unlike a mammogram, there's actually almost no compression. We all know how uncomfortable the compression of a mammogram can be. The compression with PEM is really just enough to sort of keep the breast from moving around when you breathe. So it's much more comfortable than a regular mammogram. So This is a similar setup to yet another type of nuclear imaging technology that's called molecular breast imaging, or MBI. And here's a nice example of this technology where we see the tumor in the breast here, as denoted by the red arrow. And we see it much more clearly than we can on the mammogram. I'm not sure we can really see it on these mammograms. So many of you, here's another technology. Many of you are no doubt familiar with the imaging setup of a breast MRI, right? Where you lie face down and you can see the tumor here in this MRI image in the yellow box. Well, there's a molecular imaging setup that works similarly to MRI so that we can compare the findings on those imaging studies to the MRI scans a little more easily. That technology is called dedicated breast PET. And the images look like this. And this is actually the type of setup that we use at my institution, UCSF. And I want to show you a case actually we had earlier this month that to me really shows the promise of this technology and the value. This is all sort of new stuff here. So this patient just got diagnosed with breast cancer. And the red arrow here shows what her tumor looked like on her breast MRI scan. Now, on that same day, she came in and got a dedicated breast PET scan. But now you can look, a PET scan can show you a bunch of different things. For the scan I'm going to show you, we set it up so it would show us where there are a lot of active estrogen receptors. And we can see a hot spot right where her tumor was on the MRI. And what that told us is that her tumor had a lot of active estrogen receptors. So after these scans, the patient started on a medication that was meant to block those receptors so that hopefully we could stop the tumor from growing. After 3 weeks on that medication, we imaged her again, and her follow-up MRI, really there wasn't too much change. It looked very similar. But interestingly, it completely disappeared on the PET. And what that told us was that the medication was probably doing a very good job of shutting down those estrogen receptors. And what we hope is that in a few more weeks, we'll start to see some differences on the MRI as well. But that perhaps the change in the response to therapy, we're starting to maybe see first on the PET scan. So just to sum up the different technologies that we have in molecular imaging to look at the breast, we have positron emission mammography, molecular breast imaging, and dedicated breast PET. And none of these are meant to replace mammograms by any means or breast MRI scans. Those are all very established and important technologies, but they are very promising tools that can give us complementary information, which is very exciting. The next thing I want to talk about is surgical planning. So obviously, once a breast tumor is diagnosed as breast cancer, many patients are able to have that tumor removed surgically, right? When surgery is done, however, it's really important to check and make sure that the tumor hasn't spread outside the breast. And the first place that it's going to go is going to be into some lymph nodes in the armpit. This is an anatomical illustration of the breast here, and those green ovals there are those lymph nodes I was talking about. Lymph nodes are part of the lymphatic system, which is a part of the immune system that's basically a bunch of lymph nodes connected by these channels that go between the lymph nodes, and it's constantly filtering and draining all the tissues around it, trying to get out all the nasty stuff. And lymph nodes help catch harmful substances in the body that have gotten into the lymphatic system. And there are immune cells that live in the lymph nodes that try to identify and hopefully kill any bad things like bacteria or tumor cells that get into them. So they're kind of like heroic in that way. The lymphatic system is an unsung hero. So let's imagine here that this yellow star is a tumor in the breast. Now, there are different lymph nodes that drain different parts of the body. And actually, every single person has like sort of a different configuration of their lymph nodes. It's totally different from person to person. But for the breast, the lymph node that drains the breast is usually always in the armpit, like I mentioned. But which one? We can see on this illustration how many there are. And actually, in reality, there are even like more than this. This is sort of under showing how many lymph nodes there are. So let's say that this blue lymph node here that I've isolated, that little oval, let's say that is going to be the node that happens to be the first stop for all the lymphatic fluid that's coming from the breast. Well, if a tumor cell is able to escape from that breast tumor into the lymphatic system, the first thing it's going to encounter is that lymph node. And if the immune system is not able to contain it, tumor cells can then spread from there to the next lymph node down the chain. and then the next lymph node down the chain, and so on and so on. So that first line of defense, that first lymph node draining the breast, is very special, very important. It's called the sentinel lymph node. And it sort of watches over the breast tissue like a sentinel. And it's going to be the first to know when the breast tumor has spread. Now, when the breast tumor is taken out at surgery, the surgeon often will also take out that sentinel lymph node to see if there's any tumor there. It gets examined under a microscope, and if there's no cancer in that node, it turns out that this has been going on since the 70s. And so decades of research has shown that there is a greater than 95% chance that if there's no cancer in the sentinel lymph node, there's no cancer in any of the other lymph nodes either. So those are pretty good odds. I'll take those odds. If there is, on the other hand, cancer in the lymph node, in the sentinel node that was taken out, then more lymph nodes need to be removed from the armpit and checked as well. And so it all really hinges on the status of that sentinel node. Does it have cancer in it or not? But there's just one problem. Like I said, everybody has a slightly different configuration of lymph nodes, and different nodes for different people drain different tissues. And so how are we supposed to know in a given person which one is the sentinel node? Which one does the surgeon take out? You can't tell just by looking at it. So nuclear medicine has a solution for this. So what we do is we inject a very trace amount of a radioactive substance into the breast. And it's either going to be near the tumor or near the nipple. And that substance is going to get filtered into the lymphatic system. And guess where the first stop will be? The sentinel lymph node. So once the patient is in surgery, the surgeon can then use a special probe that can detect that trace amount of radiation that ended up in that sentinel lymph node. So they can easily find it and take it out via a much smaller skin incision too than if they'd had to sort of search blindly for the sentinel lymph node. Now, there are actually some cases where we actually might want to take a picture. We might want to use a scanner to take a picture ahead of time of where that sentinel node is, especially if a patient has already had some lymph nodes removed in that armpit before. There are other reasons too why you might want to take some images ahead of time. This is called lymphoscintigraphy, and I'm going to show you some example images here. The images I'm going to show you here are basically a horizontal cross-section through the chest. Okay, here's the first patient. The patient is lying on their back, and the part of the body that's facing the top of the slide is going to be the breasts. And that yellow hot spot there is the site in the breast where the radioactive tracer was injected. And this yellow hot spot in this image, this is a little bit further up at the level of the armpits, and that yellow hot spot is the sentinel lymph node in the armpit. But it's not always that straightforward, okay? So here is a patient this patient previously already had all of the lymph nodes in her armpit on that side surgically removed. So we weren't sure where the new sentinel lymph node was going to be. So here I'm showing the injection site here in the breast, and the sentinel lymph node actually ended up being in the armpit on the opposite side. So that was very unusual. Definitely would not have been obvious to the surgeon to look on the opposite side armpit. So imaging here was very, very important to help identify where that sentinel node is ahead of time. The scanner that takes these pictures is called a SPECT scanner. And that trace amount of radioactivity that we injected actually gets picked up by a detector called a gamma camera. And over time, it can make images like this. If we just let the camera sit there and detect the radiation for a few minutes, it makes these two-dimensional images called planar imaging. If instead of letting the camera just sit there, we actually make it rotate around the body like this, we can actually take a three-dimensional picture of the body. And that is how we get cross-sectional views of the body. And like I showed you, they can be very helpful. Okay, so the next area where molecular imaging shines is in looking at the whole body, trying to find metastatic disease or tumor that has spread outside the breast. Here's an example of a normal PET scan. And here's a scan with, unfortunately, a lot of metastatic disease. So how do taking these pictures work? So to start with, we inject something called a radio tracer into the bloodstream. And that's going to help us see if there are tumors anywhere in the body. The most common type of radio tracer is actually just a type of sugar. It's basically just a sugar. And we use sugar because most kinds of tumor cells use a lot of sugar. And we want to kind of be able to catch them in the act of doing that. Now, we could just take sugar water and inject it into the bloodstream. But the problem there is that we would have no way of knowing, once we injected it, where the sugar went once it's inside the body, right? We have no way of seeing that. What we need is some way that we can peek inside the body and actually be able to see where the sugar went in the body. That way we would know where the tumors are. And so what we do is we attach a tiny radioactive atom to the sugar. And then when we inject the sugar, we can see exactly where all the sugar went, right? Because we can take a picture of it using a PET scanner. And like I mentioned, sugar tends to collect where there are tumor cells. And so here's where a PET scanner looks like, empty. And then a person lies on their back in it. It's a sort of a donut hole that a patient lies down inside of. And the PET camera detects the very small amount of radiation in the body. And we end up with a picture of where all the sugar went. But the real power of this kind of imaging comes when we join two things together. And that is a CT scan that shows us where all the different tissues are in the body and kind of what's what. And the PET, which shows us what's happening in those tissues. And that gives us a PET CT, which is a type of sort of hybrid imaging where we're fusing two types of information together, and both are greater than the sum of their parts. So here's an example of what PET can do. I'm going to show you a scan in a patient who was just diagnosed with breast cancer. And the images I'm going to show you are going to be a side view, so sort of like this orientation. So the main thing that you're seeing, the main white thing that you're seeing going down the length of the body is the spinal column. And this was a CT scan, and this scan was normal. In other words, there was no metastatic disease, no tumor outside the breast was seen. However, the PET scan that was done at the same time showed, unfortunately, a very extensive amount of tumor in lots of bones, including the spine, the breastbone, the upper legs. And so we're able to actually see a lot of things with PET that regular imaging can't show us. Here's another example. This time I'm actually going to show you just what's in that little box, just a really small little bit of the lower back. Now, this patient, before starting chemo, got a CT scan, and what it showed was a tumor in one of the vertebral bodies in that spinal column, and that's the white thing that we're seeing in the blue circle. Sure enough, on PET, there was a hot spot in that same location, and what that told us was that this was an active bone metastasis. In other words, active tumor in the bone. After chemotherapy, the patient got imaged again, and the CT scan looked exactly the same, but on the PET scan, it had almost disappeared. We almost can't see it anymore. And so that let us know that there was a response to treatment. And we may not have known this if we'd only gotten the CT scan, because on CT it looked the same. So different kinds of imaging can really help give complementary information. Now, some colleagues at my institution recently did an analysis where they compared regular imaging to molecular imaging for looking at the whole body, for looking for tumor in the whole body in breast cancer patients. And they found that regular imaging had more false positives than PET imaging. Patients had a longer time until they were able to start therapy when they got conventional imaging. And that even though PET imaging is more expensive up front, because there are fewer false positives and shorter time to therapy, the PET scan actually saved money in the long run compared to regular imaging. So those were very interesting findings. But actually, we don't have to confine ourselves to looking at where sugar is going in the body. We can use PET imaging to look at a ton of different things. And one interesting thing that we can do is, instead of sugar, we can use estrogen. And we can actually take pictures of where estrogen is going in the body. Estrogen is just a hormone, and it happens to be a hormone that sometimes can be involved with breast cancer, in estrogen receptor positive breast cancers in particular. And some types of breast cancers are very hard to see on regular imaging or even on the sort of sugar PET, the more common sugar PET, but they can actually be seen very well on this estrogen PET because those tumor cells have a lot of estrogen receptors. One type of breast cancer that can be difficult to see on imaging is lobular breast cancer. So here's a case of a patient with lobular breast cancer, and we didn't see much on the CT. We didn't see much on the sugar PET, but we were actually on the estrogen PET able to see that unfortunately she did have extensive metastatic disease in the bones, and we may not have known about that if we had only looked at the sugar PET. So this estrogen PET radiotracer is a pretty new development in the medical world. It was just FDA approved in 2020 under the brand name Cerianna, and it's something that we're just getting going with at institutions around the country. So I know this has been a whirlwind tour, but I hope that I've been able to convey to you the usefulness of molecular imaging in breast cancer and all the different fascinating technologies that we have at our disposal to help find this disease and treat it better. Thank you so much for your attention, and thank you so much to SNMMI for letting me be a part of this event.
Thank you so much, Dr. Longheath. That was absolutely the best explanation I've seen of nuclear medicine and how it's being used to detect and manage breast cancer. Next, I'd like to introduce Dr. Hannah Linden. Dr. Linden is an oncologist at the University of Washington and Seattle Cancer Care Alliance in Seattle. She's a professor of medical oncology at the University of Washington School of Medicine, and she's also a member of the Semi-Outreach Breast Cancer Imaging Outreach Working Group. Dr. Linden?
Good morning. Thanks for your attention. My name is Hannah Linden. I'm a medical oncologist at the University of Washington, specializing in breast cancer, and I'm a member of the Fred Hutchinson Cancer Research Center. These are my disclosures. The work that I'm going to describe is largely funded by a program project grant in molecular imaging and a UO1 in molecular imaging as well. We've also had industry support for imaging, but also for clinical trials and for disparities work. There's a big distinction between early stage breast cancer and advanced breast cancer. We'll talk about quantitative versus qualitative imaging and FDG PET versus bone scans. And we'll talk a lot about ER positive metastatic breast cancer because this has been a challenging area and it is the most common type of breast cancer. FES PET has been shown to predict response to endocrine therapy and is currently under study in multi-center trials. It can be helpful to identify tumor heterogeneity. We'll also talk about some future directions and some other tracers. So when is molecular imaging useful? Well, sentinel node mapping is now standard of care and is a huge advance in the care of patients because we don't take the full axillary node dissection. But for more advanced tumors, and by that I mean stages 3 and 4, PET imaging can be very helpful to look at the extent of the nodal burden and to also, in stage 4 disease, measure the activity of a molecular target. And FES for this, the prostate cancer community is using PSMA for this, and neuroendocrine tumors can be seen with dotatate. So bone soft tissue dominant metastatic breast cancer is an important subtype. It's actually our most common metastatic presentation, and it has a very favorable prognosis, and these are the patients that very likely benefit from endocrine therapy. They've been poorly studied because they don't have measurable lesions, no resist measurable lesions, and selection of therapy and management of toxicities is essential here because a poor therapeutic index means poor adherence. The current ECOG-ACTRIN trial, EAI 1183, is helping to address this issue. And so these are just some examples of the complementary benefit of different types of scans. Use the arrows to guide your thinking here, but in the top panel you can see a sternal-lytic lesion very well by FDG PET, whereas the fluoride scan really misses this. Similarly, the sclerotic lesions in the spine, which are really healing bone, probably not active lesions, are seen very well by the fluoride scan and really poorly by the FDG PET scan. Many patients have a mixed array of lesions, partially due to the timing of this imaging, but also partially just due to the type of lesions they have. And so you can see different types of lesions better with each type of scan, and this is why we think they're complementary in efficacy. So what's useful about FDG PET? Well, we get a quantitative number. We get a level of brightness, the specific uptake value. And you can see that it's pretty hot in the panel on the left and pretty cold in the panel on the right, suggesting a metabolic response. This is useful for determining the efficacy of therapy because those lesions are still there, they're still bone healing, and the bone scan would remain positive in this setting. So FES PET is particularly useful for ER-positive breast cancer. And this is a disease which is evolving in its treatment and prognosis because we've got better therapies. So we now know that late recurrences are common, indolent disease, slow-growing disease is common, and these bone-dominant lesions are common and difficult to measure, hence difficult to study. And so we lack evidence to guide us in terms of treatment-making decisions. So new refined approaches are needed. Improved endocrine therapy, improved molecularly targeted biologic therapies, and better strategies to map the sequencing are needed, and imaging can help here. So just a brief history of ER-positive tumors. You can see that we've known about this target for a really long time. We knew that oophorectomy was effective, removing the ovaries, over a century ago. But only in the 70s did we really get effective therapy with tamoxifen, actually, which supplanted DES, high-dose estrogen. And the way we measured the target at that time was radioligand binding, a quantitative assay of really how the estrogen and the receptor come together on a piece of tissue. And this required really delicate handling, and therefore all labs were not able to do it. This was seen more as a prognostic feature, something that would tell you how a patient would do, but now it's obviously predictive of response, and we understand that better. And we tend to measure this now by immunohistochemistry because it's a more robust assay. And we also now have an appreciation that premenopausal women who are ER positive also benefit from endocrine therapy, whereas prior to this time, we actually only thought that postmenopausal women benefited, which obviously doesn't make sense because the premenopausal women benefited from having their ovaries removed. So recent advances, aromatase inhibitors, now standard of care, are a little bit better than tamoxifen. Tamoxifen is still a good drug and probably the most widely prescribed oncologic therapeutic in the world. We know that aromatase inhibitors are superior to tamoxifen. Tamoxifen is still an active drug. It's the most widely prescribed oncology therapeutic in the world. Fulvestrant is now the standard of care in the estrogen receptor blocking category and is FDA approved and very active. But under study currently are many oral agents, which I think will be more tolerable and pleasant for patients rather than a 5 cc intramuscular injection. Molecularly targeted agents clearly add benefit, and we have 3 FDA-approved CDK4/6 inhibitors, Palbo, Ribo, and abemaciclib. We also have everolimus, and these have improved outcomes dramatically for patients, suggesting maybe that for a subgroup of patients, chemotherapy is really inappropriate. And I think this is what research needs to be done, is to figure out the sequencing and subgroups who benefit from these agents, and that's not entirely well defined yet. So how might imaging help us? Well, it can show you whether the target's present if you have a tracer of that target. And if it's present, then you could decide to use the drug. And if it's not present, you could go with a different strategy. And if it is present persistently, then you would continue the therapy. So I think we're at the point where we can do this. FES PET, like immunohistochemistry, demonstrates a functional presence of the estrogen receptor in the concentration of the ligand, meaning estrogen, but it doesn't measure downstream events like proliferation or progesterone receptor. It identifies, however, which patients are unlikely to respond to ER-directed therapy. So it's a double negative, and it's kind of confusing, but the point is that it identifies which patients will actually get some clinical benefit, and that includes response as well as stable disease. So here are some examples of FES. You can see that it's really showing you that supraclavicular node in an ER-negative patient by FDG, but you can't find it by FES. These are somewhat older images and a little bit more blurry. It also shows you that the liver is always positive on an FES scan because that's where the tracer is metabolized and cleared. So the bottom panel shows you an estrogen receptor positive tumor in the breast, and you can see that it's very strong by FES and actually kind of stronger than the FDG uptake. So part of the reason I went through the history is what FES really is it's in vivo radioligand binding. It's in your body what the estrogen receptor is doing. And we've shown that it aligns nicely with immunohistochemistry staining. So FES is helpful in later stage disease, specifically stage 4, but probably also stage 3. We don't think it's so helpful for early stage disease because those tumors are too small. It's giving you a macroscopic picture. And this is just another example from a study we're nearing completion of in the cooperative group ECOG Akron, looking at FES as a biomarker to predict response or clinical benefit to endocrine therapy. On the left, you see a patient who has uptake at all the sites that are positive by FDG PET. And on the right, you see a patient that has no uptake at those same kind of sites. These are mediastinal nodes. Notice that there's a lot of nonspecific uptake here in the liver and in the intestinal tract. So unfortunately, FES is not useful to guide discernment of whether or not those sites have metastatic disease. Here we see an example of where FES shows the same sites actually that we see by FDG PET, but you can see they're just much brighter. It appears from this picture that you can find more sites by FES PET. But when we looked at this more carefully, the sites were there by FDG PET. They just had a very low uptake, a low proliferative index probably, and this is where FES might be a little more useful to really show you the extent and activity of disease. These are all nodes and soft tissue and bone sites, no visceral disease in this patient. So we've looked at those two features, the FDG proliferation, the quantitative value, and FES, and shown that the indolent tumors, really slow-growing tumors, and patients do quite well. Patients with high FES uptake, even if they have a higher FDG uptake, also do pretty well, and the patients who do poorly are the ones with high FDG uptake and a low FES. And those patients probably are not well served by endocrine therapy, even with molecularly targeted agents. So what are the benefits of imaging? We get quantitative and qualitative data from all metastatic sites, and we can capture the functional status of the tumor at each of these sites. We can characterize the locations, maybe predict some complications such as ureteral obstruction or bone pain or compression fracture, and we can identify patterns of spread. Importantly, we can identify potential sites to biopsy and maybe identify potential sites to ablate using radiation or stereotactic radiation. So here is an example of tumor heterogeneity. This patient has a tumor in her breast that is FES avid, and actually there's an axillary node that's FES avid, but she has lots of other disease that you can see by FDG PET throughout her axial skeleton, and she has liver lesion, and those sites did not take up FES. So we biopsied that liver lesion and actually showed that the phenotype was completely different than the breast. It was HER2 positive and ER negative, and we used completely different therapy based on that biopsy. Similarly, this patient had heterogeneity in a bone lesion over time, meaning her bone lesions were FES avid, and then they became negative, and then they became positive again. And not surprisingly, she benefited from chemotherapy when the bone lesion was negative, and she benefited from endocrine therapy when the bone lesion was positive. This is the exact same site that itself changed from hormone receptor positive to negative and back to positive. So you can see where it's appealing to think of using estrogen receptor imaging to determine appropriate therapy. So ER expression, it's the standard of care to biopsy it and measure it, not just say, oh, it looks like the primary tumor, but to actually measure ER expression. It's also the standard of care to measure HER2 expression, and now to look for mutations that might make you a candidate for a therapy that targets something like PI3 kinase. So FES can't replace biopsy in that it doesn't measure any of those other important targets. But it's been historically assayed by ligand binding, and now you have an in vivo ligand binding tool, which is FES, and we use IHC for standard biopsies. We also use more sophisticated molecular measurements to look for mutations and other targets. I think what's important is that FES shows you the span of disease across the whole body, and therefore you have a sense that the biopsy you got is representative of what's happening everywhere else. I think FES can be used here to determine whether further estrogen receptor-based therapy is indicated. We don't really know from clinical trials yet whether or not you should use a CDK4/6 inhibitor and then use another one. But I think we have a hint based on ER functional imaging of what would be appropriate to use. And I think the approval of FES is really going to help us manage patients. So where are we going in the future? Well, we have trials underway now looking at FDG PET to measure response in bone, and at the FES trials here and in the Netherlands are completing accrual, and I think will give us a wealth of data to look at the value from a qualitative and quantitative standpoint, and to help ensure that you can conduct multi-center trials and that the anecdotes from each of our institutions don't represent something that is not something that can be shared with other sites. I'm very confident, based on what I've seen from the data from the Netherlands and our work, that this is a robust assay and that these trials will be positive, but they're not published yet. We also know that infiltrating lobular tumors are challenging, and that the triple positive tumors, HER2 and ER positive tumors, are a little bit confusing. FES, I think, can help there, and I think we can learn how to integrate molecular imaging into the modern treatment algorithms. I think we have some other tracers that are going to be very helpful for us. Looking at HER2, progesterone receptor, as well as PARP inhibitor, I think these will make a huge difference in the management of breast cancer patients. I thank you for your attention. The summary here is just that molecular imaging is very useful in breast cancer, but really only appropriate for the macroscopic patient with stage 3 or 4 disease, not appropriate for early stage detection. It's not a screening test. And bone dominant disease can be really difficult to assess, and I think FES and FDG PET are extremely helpful here. FES is now approved to predict benefit from endocrine-based therapies. I want to thank patients who participated in trials and served as advocates. We couldn't do this without you. And really appreciate the leadership of Ken Krohn and David Menkoff and Paul Kinnihan to support these major grants that have supported our work here, and also my multidisciplinary colleagues at our center and across the cooperative groups. And I also want to thank Zynexa and now GE for getting this tracer across the finish line so that it is approved for the use of imaging in patients today. Thank you.
Thank you, Dr. Linden. That was really some very useful information for patients who are navigating this disease. Finally, it is a great honor for me to introduce you to my friend Valencia Robinson, who's going to share her personal story going through the breast cancer journey. Valencia was diagnosed with triple-negative breast cancer in October of 2006. This ignited her passion to be an advocate for others. Valencia is a board member of the Florida Breast Cancer Foundation, and she serves on the triple-negative advisory board of the pharmaceutical company AstraZeneca, where she advises the company on clinical study design and planning efforts in order to optimize the patient experience. She also works with the Department of Defense Congressional Directed Medical Research Programs, specifically the Breast Cancer Research Program, which challenges the scientific community to design research that will address the urgency of ending breast cancer. Valencia, let's hear your story.
Thank you, Jerry Francoeur, for that introduction. It's great to be with you today to share my breast cancer story. I am Valencia Robinson, and I was diagnosed at the age of 33. I was a classroom teacher with a 3-year-old, 4-year-old, 5-year-old, and 8-year-old. It was a devastating journey for me, being so young and not really knowing how to navigate through this cancer journey. So I was not doing my breast exams, but I had a great relationship with my medical team, my OBGYN, and I went in for a routine appointment, and she felt the lump in my breast. Put my finger on it, and I felt it as well. And she did not let me leave the office until she had a mammogram scheduled for me. So I went in for my mammogram. I then had the biopsy, and I get this diagnosis of breast cancer, October 31st. it just really, truly wrecked my world because I had the children, I had a family, I had a job, full-time job, teaching high school English. But I knew and I felt that I could make it through whatever I needed to make it through. Not knowing the type of cancer, but just knowing that, hey, whatever I have to do, I will do what I need to do to get through this. So I first encountered nuclear imaging at the very beginning of my diagnosis because I had so many scans, PET scans, to see if it had spread to any other parts of my body. And once we got the diagnosis of triple negative breast cancer, then we knew what I needed to do for my treatment plan. Had the lumpectomy, and then I immediately started chemotherapy. Now, the chemotherapy we had a really detailed conversation about when I should have my chemo, what days I should have it, because I decided that I would continue working. And personally for me, I needed my health insurance. So there was never a day or moment where I thought, hey, I just have to quit work and go through this journey. So when I went to chemo Monday after school, that was the best day that my team came up for me because she explained how 2 days after chemo is when you're really going to feel lethargic. So I would go to chemo on Monday after school, go to work on Tuesday, go to work on Wednesday, and then by the end of the afternoon Wednesday, I would start feeling it. And then I would take off on Thursday and Friday so that I would have time to recover without the kids being at home. They were in daycare, they were in school, so that was the perfect plan. And then on the weekends, I would gradually get my strength back so that I can go back to work on Monday. So we're talking about 8 months of this schedule of treatment, work, scans, all of this. After I finished all of my chemotherapy, because of the type of breast cancer that I had, at that point, my doctor told me that I needed to have a double mastectomy. Now, I know now, this is years later, that that was the option that they gave me, but now I know that really and truly, I should not have had a double mastectomy. So I go in, and again, school has started. So I have to coordinate everything around my school dates and vacations and any days off from school. So I had the double mastectomy with the tissue expanders, and that process was a complete nightmare because my body rejected the expanders. I didn't even get to the point where I had the implants, but the tissue expanders, it's a foreign subject going into your body. So my body rejected them. So I had to take them out. And when you take out these expanders, then I'm left with two gaping holes in my chest. I mean, it was the size of an orange. After that process, I had to have nurses coming into my home every day to address my wounds, to clean out the wounds every single day until it was determined that maybe a wound vac would be better for me. So then I got attached to the wound vac, and then I only had to go into the doctor's office maybe once a week for them to assess my wounds, because that wound vac stayed on me every single day, 24 hours a day, and it suctioned out all of the fluid. After that process, and I had to go in for a final surgery to just get closure on my chest. So I get my chest closed up, and I'm 34 years old, and I'm devastated looking at myself with this chest. But I had to get over that because I know what I felt in my body when I had the tissue expanders. And what's the alternative? Keep something in my body that can ultimately cause me more harm, or just get them taken out and live with the fact that I will have a flat chest for the rest of my life. It was hard. It was very, very difficult. I cried a lot of days, but I started yoga. My oncologist introduced me to yoga, and she said, you've gone through so much. And it was so hard because of the surgery on my chest, because of the tissue expanders, having to take them out, and then having the surgery to close my chest, no strength in my arms. I was walking the wall. I was doing everything I could. And yoga was extremely difficult. It was so difficult. And I would sit in the yoga studio and cry. But my oncologist, she said, she was teaching at the studio, and she said, just keep coming. You're going to be able to master yoga. You're going to be able to get your strength back. You're going to be able to, it's going to take time. You have to be patient. And she even offered me to come to yoga at her office. She did yoga with her staff in her office. And I would go there twice a week, along with the classes that she taught at the local studio. And it took a lot of time. And yoga is one of those things where you're forever practicing. It's not like you just conquer yoga. No, you're always learning. You're always perfecting, your poses and everything, breath work. So many aspects of yoga were so crucial to my healing. The deep breathing, the stretching out my arms and everything. It was so beneficial for me. And my doctor, because of the triple negative disease, she had told me that I may not make 5 years. And I've seen so many ladies, people who are diagnosed with the same type of breast cancer that I had, who did not actually make it to 5 years. So the things that she encouraged me to do, like yoga and my diet, and just overall getting more sleep and making sure I'm drinking a lot of water, and just spending time in nature and reflecting and taking trips with my kids. I grew up on a farm. So we would go to my mother's farm and just walking around the farm, fishing in the pond, and just being there, being at peace. I spent a lot of my time doing that. So after all of my treatments ended, that's when I really started with the nuclear imaging. For every 3 to 6 months, I would go in for my PET scans. I would get injected with the dye, and I would sit and wait until they were ready for me to scan my body. And I did that. And it was, this is your post-treatment surveillance, right? So these are things that are crucial, especially when you have an aggressive type of cancer, so that you can see if anything is. I may not have felt like anything was brewing in my body, but it's these nuclear imaging scans that really detect if the cancer had indeed spread to any other parts of my body. So that went on for 5 years. After the 5-year point, it was determined, okay, so I can back off the scans and get my scans once a year. And I actually kept my port in for 10 years. I did not get my port out until 10 years. My doctor was like, well, if it's not bothering you, let's just keep it in, because even though you made it through the 5-year mark, let's just keep it in. And during that time, my sister was diagnosed with breast cancer. So I had gone through everything, and I was able to assist her in her journey, traveling back and forth to Tallahassee to be with her for her treatments, and just speaking with her doctor and making sure that, she had the support that she needed. So I have some photos that I want to share with you of me doing my yoga. Well, the first photo, the SeaWorld photo, is me and my children, me when I lost all my hair. I lost all of my hair after my very first treatment. That was traumatic, but hey, it grew back. And you see my yoga poses, it's really so inspiring to others to see me doing my handstands and all of the things that I do. I like to travel. I like to share my story. I just want people to be inspired to know that they can make it through, any type of cancer diagnosis. But you have to be strong and patient and willing to go through, every part of it. And part of it is recovering and doing exercise and just being empowered and to make it through, whatever you're going through. So thank you so much for allowing me to share my story.
Thank you, Valencia. We appreciate you sharing your powerful story and your tireless commitment to advocacy for breast cancer. Now I'd like to bring in all of our speakers back to discuss the patient poll and answer your questions. The poll on the first question, I would prefer to get my imaging report, as soon as it is read. There was 85% saying yes to that. B, at the time of my appointment with my medical team, that was 15%. The second question was, are you concerned with the number of scans you're receiving? A was yes, 44%, and no was 56%. And the last question was, as we enter the second year of telehealth, I prefer A, telehealth appointments, that was 25%, and B, in person, that was 75%. So any of my speakers want to elaborate on the poll and what you think?
Well, I think the response to the first question is very interesting. The question about whether people would prefer to receive their imaging reports immediately as soon as they're read, or if they prefer to sort of wait to go over it with their provider, like their oncologist. This is something that's been sort of a hot topic recently at my institution. There's this federal law that you are probably familiar with called the 21st Century Cures Act, and it does mandate that radiology, one of the many things it mandates is that radiology results be released to patients immediately. And there was a lot of patient demand for that. If it hasn't rolled out at your institution yet, where you go, I'm sure it will. It's been sort of rolling out slowly across the country. We recently implemented it at my institution, and despite all the patient demand that I'd heard about, the main thing that I heard back was a lot of actually increased anxiety. We were getting a lot of patients who were getting these reports and kind of were overwhelmed, didn't have any way to contextualize them, and it ended up causing a lot of stress, both for the patient and then for their oncologist, who was kind of struggling to keep on top of that. In fact, actually, I just very coincidentally just happened to get my routine screening mammogram yesterday, and I got my report. I got a notification on my phone before I even got a chance to get back to work that the report was ready. And so I don't know. I think it's interesting that so many people prefer to receive their imaging report immediately, because, like I said, the most vocal voices, at least where I am, have been those of anxiety. I'd be curious to hear Dr. Linden's perspective, and also Valencia's perspective on that.
All right. So I think it's mixed. I think people want to know what they got and they want access to it. They don't want to wait till an appointment. I got a lot of patients who kind of want to think about it before we talk. But I think what's hard is that the report can be, frankly, very confusing. And so then there can be just all kinds of anxiety about non-specific findings that, I just feel terrible that people worry about them. So one solution there is to come up with a way to write more patient-friendly reports, and that is a project that we're working on for both pathology and radiology. But I think that it's great that you get access, but it's terrible that it's kind of a technical gibberish that can lead to anxiety.
So if we can't understand what we're reading, what's the point of having it so fast? Now, fortunately for me, I did have a team that I could reach out to and like, I don't understand this. I don't understand this. Can you expound? But most people don't have that. And it's just a lot of information. Too much information can cause us to have even more anxiety, like you said. So, but some patients have medical backgrounds, some patients are doctors, some patients are nurses, so some patients are up to speed. So it just depends on the patient, really.
Right, but what I think you're hitting the nail on the head, though, is that we have a thing now with the electronic record where the patient can ask us a question, and that's what we want. Is we want them to be able to get a quick answer, so they're not really worrying about that non-specific thing that has nothing to do with anything and is not something to worry about. So I think that's important that you be able to get your questions answered at least in a preliminary way, really kind of urgently, so you don't let something fester.
I know with the patients I work with, a lot of them, the anxiety of waiting to talk to their medical team may take 2 to 3 weeks. I'm lucky I get my reports immediately. My docs call me. I also have their backline numbers. So, but the ones that have to wait are really split on this because they really want to know it right then, but some of them don't. They want to have the support there when they're told as well. And the time, at least in the area where I'm living, is it's 2 to 3 weeks before they get the results, and that's a lot of anxiety for them.
Yeah, that just seems like
Well, what I think all of the rest of you are all pointing towards is that these reports need to be. We need to start being more mindful that it's not just other doctors that are reading these reports, but it's the patients too, and we need to definitely revamp how we approach our reporting.
Yeah, Valencia and I spend a lot of time calming a lot of people down, especially with Florida breast cancer. We do the underserved and uninsured. So that's a population that you really have to work closely with. As far as the one saying about if you're concerned about your number of scans, that was pretty well split between yes and no. Any comments on that?
At the time that I was scanned, I just went with what my doctor told me to do. I didn't even think about the harm that it could be causing because, especially in my situation, if someone is told you may not make it 5 years, then hey, I want to do whatever I can to live. So with that, you have to go through the processes, and maybe I was scanned too much, but I'm still alive. So I'm grateful.
The third question is on telehealth. Now, Valencia and I are a little different because we're in Florida and our state is open. So it's a choice. Not many, I see you rolling your eyes. But we haven't really had that much incidence. I mean, if they want telehealth, they get it. But bottom line is you can go see your doctor here without a whole lot of issues. How is that going with where our two physicians are?
I think telehealth is really a nice advance. It's fun to see people in their homes, and the majority of what we do is talk, so that can be done by telehealth. Where it obviously doesn't work is we can't feel things, we can't measure things, and even though the video is great, we can't really see things either. So I think it's got to be a mix, and our center's been able to really, I think, keep people very safe, and we are seeing people in person, the majority. But I think telehealth is a wonderful tool.
Yeah, we've made a big transition over to telehealth during the COVID period, and our had just started to sort of retransition out of it, and then sort of another wave. I'm in California, and another wave came, and so things have are a little bit more locked down again. In my particular specialty of nuclear medicine, I don't see patients every single day, but I do have a clinic day where I see some of our therapy patients, and I'm very much, I have to say, looking forward to the return of in-person visits. I totally agree with Dr. Linden that it's an amazing tool. It's wonderful to not have to commute. And for patients that come from really far away, it's a huge a game changer to not have to, drive for hours and figure out lodging in San Francisco, for instance, where I am. But I don't know, for me, there's something about that in person, I don't know, that human connection that is just somehow lost in telehealth a little bit.
Yeah, there's a
If you
about
can let me see
tamoxifen.
the questions, we'll do the ones from the audience.
Yeah, I saw the question earlier with
Um,
about the
the first
duration of
one is, I'm
tamoxifen.
going into my 5th year on tamoxifen. There are people that say that I'll be on it for 10 or even 15 years. What's the leading research saying?
Yeah, that's a great question. 5 years is our standard package, and you get the most bang for the buck out of the first 5 years. If you have a higher risk situation, pushing it to 10 may be a better idea. But I think for the average low risk tumor, 10 doesn't get you that much more than 5. And it is being looked at for 15 years. I mean, unfortunately, breast cancers can recur late. But I think the thing people have to realize is if you invest in taking your 5 years of tamoxifen, that's still going to help protect you even when you're not taking it, which is kind of counterintuitive, but true. So the patients who benefit from the longer duration of therapy are the ones with higher risk disease, meaning many nodes positive.
Okay. Next question. I was diagnosed and treated for breast cancer in my 40s. Could or should my daughter have genetic testing to determine her risk level?
Good question. But the person who should get tested is the patient because she can't give a gene to her daughter if she doesn't have the gene. So we test everybody, and really we're testing them now because if we find a deleterious mutation in BRCA1 or 2, you can actually benefit from adjuvant PARP inhibitors. There's a pill to take, so it's a different therapy. But the other reason you want to get tested is that way other people in your family can get tested for this particular gene you have if you have it, and the majority of people don't. So the advice for the daughter is to get screened in her 30s, actually, because the mom had breast cancer in her 40s. If the mom actually has a known mutation, then the daughter can be tested for that specific mutation. And if she doesn't have it, she can go back to getting screened in her 40s.
Okay, well, I have a follow-up question to that because I am seeing a lot of patients who pass away. So maybe the mom did not get tested.
Right.
So the daughters, the relatives have no idea because the patient never got tested. And in Florida, everybody doesn't just get automatically tested. And in my instance, they denied my test, but my oncologist fought for it. So I was able to get my testing done.
That's what we should do, and that's what we do is we fight for the right for you to be tested because you should be tested because it's just super important because if you don't have a gene, then we don't want to suggest taking your ovaries out or other preventative things, and we don't want to worry your family about that. But you're asking, what do we do if the person who had the cancer is no longer with us? Well, you can go to a high-risk clinic and you can get the screening done. It's just much more expensive and it requires a lot more advocacy to get it covered. So that's the short answer. But the longer answer is look at the whole family tree, right? And see if there's somebody else in the family who might be the one who should get tested. And this can be more complicated because some people don't want to be tested. But often you can communicate with the extended family and work it from there. And then everybody can get benefit from knowing these things because these genes are relevant. The same genes are relevant for more than breast and ovarian. There's also prostate and pancreatic that comes up here. And so it's important to try to help families.
Okay, we can go on to the next question. In metastatic lobular breast cancer, can FES be used even if an ER positive patient has been on 3 lines of ER positive therapy to see if there's something FDG PET CT has missed?
And the answer is probably. There are a couple problems. So if you're actually on a blocking therapy right now, like tamoxifen or fulvestrant, then FES PET won't be helpful because it's blocked. The tracer is blocked. So if you're on an aromatase inhibitor, then you can do FES and we can see what it shows. I wish I could say it's going to solve all the problems for lobular patients. It's only going to solve some of the problems for lobular patients. I still feel like it's the tip of the iceberg that we're seeing, but you can see more of the tip with FES if the tumor is strongly ER positive than you probably can with FDG PET. That's been our experience. So the disappointing piece is it's not showing that gastrointestinal uptake because there's nonspecific uptake in that part of your belly that's kind of just obscured by many tracers. But it's pretty good in the lungs and in the back and what we call the retroperitoneal space, the space around your kidneys. Very helpful. So I think it can add additional information. The time I'm suggesting people use it is if you're trying to figure out whether you're going to go on chemo next or whether you're going to go on an endocrine-based therapy, and that includes the endocrine plus the molecular targeted agent, then I think that FES is quite useful. Would I suggest you wait 3 months off of fulvestrant doing nothing? No. I think, that's a time for a drug like capecitabine or some other gentle chemotherapy so that you're on treatment, and then you can use the FES to figure out if you want to switch back to endocrine therapy.
I have one. What are your thoughts on oncotype testing?
For metastatic patients, not indicated. It's really proven in the primary setting to really determine how chemosensitive is the tumor and how endocrine sensitive is the tumor. So, it's going to be, the lower it is, the more likely you are to benefit from endocrine therapy, and the higher it is, the more likely you are to benefit from chemotherapy. And unfortunately, the less likely you are to benefit from endocrine therapy. So we do it for primary tumors to help sort out who needs chemotherapy. We don't do it in the metastatic setting, in part because it's just much more complicated. You're taking tissue from a different part of the body, so you don't have the background genes to compare appropriately to. But I think what we do recommend is that the metastatic biopsy get done, despite the advantage of imaging. If you can possibly get one, it's useful for several reasons. You can look at ER expression, but you can also look for HER2 or PI3 kinase or other mutations that might be targetable. So we still really do recommend ultimately that a metastatic biopsy be done in order to help determine appropriate treatment.
That was our last question. It's been a terrific session. And again, a recording of this event will be available on the SNMMI website and the YouTube channel shortly. I want to again thank our speakers. They did an excellent job. And a special thanks to all of you for joining us. Stay safe.